Hello guys, I'm just going to upload a couple of files for today and we will get going. Someone just confirm that you can hear me. It's always a little bit of an unknown when I come on, as to could have my volume switched off or something. In fact, as long as I just put that one. Loud and clear, nice one. Okay, I'm just letting my presentation upload there, guys, and then we will get going. So thanks for joining the session today. On the last group, I didn't have a attendance code. I don't know where David Byfield or Paul is. So if that's the case, then we can't do anything about it, and we just have to say that that's the case. But as I understand it, this is our split group, and for, is it group 7? Is this your 8th and final session of this calendar year with me? Okay, lucky you or not. Hopefully you find these sessions to be useful. And for the other half of this group, we are in our 3rd session. So you will hopefully see that I've been building the Blackboard, and it's in some order. I've uploaded lots of what I believe to be really cool resources that help me learn and get across these concepts. So a lot of it is optional for you guys, because I put stuff in there that you should really try and do in your own time, but it all supports this process of what we're doing. And you guys now are seeing patients, and hopefully the role play that we've been doing is a little bit more obvious now as to the importance of the interaction with your patient, because it's not easy. You have to be able to develop these communication skills, and they're otherwise known as soft skills, okay, that are often misinterpreted as important, as being as important as the hard skills. So being able to do this test well, being able to do a full, ask every question, being able to do the objective things. Well, being able to have good listening and communicative skills for influencing behavior change are probably what, in my opinion, really set the best healthcare professionals apart. They may have less of an understanding around being able to recite every systematic review on a topic to be able to give informed information, but they're able to work with a person, communicate with a human being to be able to drive behavior change, which is ultimately the business that we're in. Pain is an incredibly powerful driver for us to change our behavior. We're all reminded of that when we go through it ourselves. None of us are immune to it. I've just gone through a few weeks of neck pain, which has drove me to be able to change my behavior, change my training, change my lifestyle to try and resolve and support calming my nervous system down. So what I wanted to do for this session, which is session 4 for some, session 8 for others, will be to put some meat on going into guiding the soft skills, which a lot of people will take for granted, and I think some people are intuitive with it, and unfortunately people don't like to say the same as some people are going to be born sprinters, some people are going to be born with a much higher IQ, some people are just better at communicating with humans than other people. That's just the reality. But does that mean we can't work on it? I don't think so. And being aware of how we can try and get across the important information, I think, is worth spending a little bit of time on. So this session is going to be connected to the case study at the start. For the guys who are in the session 8, you'll remember there's a 90-minute webinar of the entire process of a rehab program for you guys to have an idea of how we put it all together. For you guys who are at session 3, that's uploaded onto your Blackboard for you to watch. Okay, so connect this session to that, because this is going to be how we guide the history and work towards opening our patient up for exploring and looking at pain slightly differently. So this, in terms of a clinical model, is a reminder of the bird's eye view of the patient presenting to us, to being able to do red flag triage first and foremost. Are they in the right place? Is this a medical issue? Is this in the 1% that is serious pathology that we need to be able to get in the people who are very good at that, which is medical doctors? Rule that out. They are in the right place for the next level of triage, which is going to be the psychosocial screening, which isn't without limitations, because humans don't fall into these nice boxes around I'm medium risk, I'm low risk, I'm high risk. We fall hopelessly somewhere in between. But that doesn't mean to say we can't put something in place to help guide us to try and work towards a more appropriate pathway of management. So you've got the start back, I believe, to be able to help with back presentations. And low risk will be that they have a very low catastrophization or psychological profile. They will generally get better with just good information and time, natural history. Medium risk is going to be some levels of psychosocial involvement. High risk, probably worth considering specialist co-management if that's even available. In my area where I work, you refer someone for psychological assessment, you're waiting 3 years. So you either say, no, this is for somebody else to deal with, or we find a way to be able to appreciate that this person's come to me with persistent back pain. Well, their depression is a part of that picture. So I've got to try and either have some open conversations around this or triage it out to be able to get the best chance of an outcome in my rehabilitation program. And that leads us on to the pain mechanisms that we want to identify as primarily at play. There'll always be a sliding scale of each one of them at different times, but nociceptive is our more tissue-based. We're going to dive into a little bit deeper, but it's our more tissue-based mechanism. People will be much more familiar with that as a cause of pain. It makes the most sense. I fell over, I sprained my ankle, it hurts. That is, why is my back not the same? I didn't have an injury. It wasn't a moment when it came on. It's just with me, and it comes and goes. Sometimes it's a bit worse. That's often very confusing because people are not able to explore, haven't been opened up to the idea that we can have central changes that are nociplastic. Okay, and in between those two will be our neuropathic pain, which is in the 5 to 10%, which is going to be radiculopathy in the upper limb, nerve root, sciatica in the lower limb, and that's an injury to the nervous system itself, which will be maladaptive from the start because the amount of tissue damage to the nerve root will cause all that pain down the leg, which is so disproportionate to the size of the injury, but the injury is to the nervous system itself. And that is going to need a more specific radiculopathy plan of management, but still sensitizing of the nervous system is going to be important for that. So that's where working through the persistent pain booklet and having that as a guide around these mechanisms is super essential for your persistent pain, because they're much more difficult and more challenging to be able to support those people towards their goals, and for also acute presentations. This information helps guide how much of our rehabilitation program is physical, just get stronger, just get more flexible, just move a bit softer, versus how much is cognitive, changing someone's beliefs or supporting someone's understanding, education, so top-down modulation or changing, and bottom-up at the same time to different extents for different people. Now, I have pulled this paper up and I'm going to upload it for you guys because it's an amazing resource. It's a 2020 paper and it's a masterclass in neurophysiological approach to musculoskeletal pain. And I've got videos I'm going to share with you in this session, because what I just went through there was this glossary that you as clinicians need to know this stuff inside out. And there's a lot of stuff that I support you guys through, saying that stuff's a little bit of irrelevance in terms of clinical practice. This stuff is what you're going to be facing every day with every person. Being able to communicate pain, that's what they're there to see you for. Okay, and that is where we got to be able to know neuropathic pain, nociceptive pain, nociplastic pain in terms of our primary pain mechanisms, because the plan of management, as we just mentioned, is going to be different for nociplastic to nociceptive. Nociceptive is pain that arises from actual or threatened damage to non-neural tissue and is due to the activation of nociceptors, which are our danger receptors. Okay, neuropathic, pain caused by a lesion or disease to the nervous system itself. Nociplastic, pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage causing the activation of peripheral nociceptors or evidence of disease. That's a lot. That's the vast majority of your presentations is in there. And managing that's different to nociceptive, where it's generally rest and gradually get going as tissue healing phases pass. So that's where it's important. I'm going to pop this in here because often people have a disproportionate pain response to an input, and you'll be seeing that now if you're seeing patients. These two terms here are probably, based on my last group, you may have heard of them, but I don't think that's something that's really on the on your radar in terms of the importance for how it might impact your assessment. And that's allodynia and hyperalgesia. Has anyone in this group heard of allodynia? Has anybody in this group, thank you Daniel by the way, has anybody in this who, saying you don't know is not an insult either, by the way guys. I have to say I don't know all the time, and if you ask me a difficult question that I don't know, I won't bullshit, I will be saying I don't know. So if you don't know, that's not a problem to be able to say that. Okay, I think a lot of people, not enough people say that they don't know when they actually don't know. But hyperalgesia, how about that one? Increased pain sensation. So we went through in our one of our central changes sessions, we went through descending inhibition, and we looked at how one bout of exercise can cause exercise-induced hypoalgesia, which means that you do a pressure or temperature threshold test, do a bout of exercise, and we went through, I gave you all the protocols, because basically in people who don't have pain, you can see after that bout of exercise, whether it's resistance training, aerobic exercise, whether it's swimming, whether it's walking, they have a reduced pain threshold, which means that, or an increased threshold, reduced pain experience, that is hypoalgesia. Okay, that seems to be dysfunctional in people who have persistent pain. We went through and had a look at that. Is that something that you guys are happy and on board up to that point? Really important for when you're giving your education around exercise to be able to frame that, because those people who have pain will do a bout of exercise and they will have an increased pain experience or hyperalgesia. Now there's a couple of there's some really useful clinical tests that I'm going to play for you guys now to be able to put this into your testing to help get this information across, potentially as part of your workup, because I would hedge based on the last group here that you guys wouldn't know how to test for allodynia. Allodynia is a painful response to something that shouldn't be painful. Hyperalgesia is an increased painful response to something that is noxious or could be noxious. Allodynia is a painful response to something that to non-sensitized people shouldn't be painful. Okay, so we're going to go through and I'm going to show you a video on how, because I pulled this from the Beale paper, which is an awesome resource. I will upload it to your Blackboard for how you would assess for both of these things.
Okay, so we're about to have a look at some assessment of your back, Jenny. But just to clarify, you've had this for nearly 12 months now, where it's really been pain in your low back, but it's just been broadly radiating down your left leg.
Yeah.
But the pain's more localised to the left side of your back. And you didn't have any specific injury or anything when this started. and you've had some scans on your back that are actually clear, so they don't show any signs of disc problems or pinched nerves or anything.
That's right, yeah.
To your understanding. Good. So we're just going to do some tests first, because you've described that this area is quite sensitive and can be easily stirred up, and similar with your leg pain. So we're going to do some tests around sensitivity. And these ones are just of your skin, so we're interested to know, even at a skin level, is your back or your leg sensitive, or is the issue deeper than that? Okay, so we'll do these tests first. If you just stand and face with your back to me, good. So I'll use this tissue, so it should feel like, if I brush on your arm, it should feel like a tissue. Can you feel that?
Yeah.
So now I really want a comparison in what you can feel on the left and right sides of your back. So if I do the right side first, can you feel that?
Yeah, I can.
And what does that feel like?
It's like a tissue.
Okay, so similar to your arm.
Yeah.
And if I do it on this side, can you feel that?
I can, yeah.
Okay. Is that different to the right?
Yeah, it's more on that side.
So is it painful, or you just feel it more?
Just feel it more.
And if I compare this again to this, do you feel it a little bit or a lot more?
Yeah, quite a bit more on the left.
So it's clearly more sensitive,
Yeah,
but not painful.
that's right. Yeah.
Okay, good. Okay, so similar to what we did on your low back, we're just going to repeat some of that on your leg now.
Okay.
So we'll use the tissue again,
Yep.
which feels like a tissue. So when I brush on this thigh compared to this thigh, does that feel any different?
Feels the same.
Okay. And if I brush on your lower leg there, can you feel that?
Yeah.
And can you feel that?
Yeah.
And do they feel any different?
Yeah, they feel the same.
Okay. So I'll just come down onto your foot now. So if we do that on your foot, compared to this side, any different?
Exactly the same too.
Okay. So interesting, it was different on your back, but there's no obvious difference there. And that's in the areas where you do feel those symptoms sometimes.
Yeah.
Okay, good.
So that is a soft touch, or what you would have potentially learned in neurophysiology is using a Von Frey or a fishing wire for being able to then compare a difference in processing from the painful body part to the opposite side, or a distal body part, to be able to see is there general central sense, is there sensitizing mechanisms at play. And that is how we might use a tissue instead of an expensive bit of neuro testing kit. That's an example of how I would do it in practice, because again, being able to use low barrier pieces of kit are really important. If you haven't got expensive kit, you've got to have an alternative where possible. So that is testing for allodynia, and I'm going to now share how we might test a couple of ways for hyperalgesia. These will all be uploaded to your Blackboard for you to be able to practice and play with these with each other, and then hopefully with your patients as well, because the questioning at the end of these tests is what I also want you to tune into. You guys, currently I know that you are able to do sharp soft discrimination as part of your primary sensation assessment. Is that correct? So this is how we're going to use the pinprick for testing for hyperalgesia. Okay.
sharp. So can you feel this here?
Yeah, it's sharp. Yeah.
Yeah, it's okay though?
Yep.
Okay, so same routine. First of all, I'm going to go on this side, this knee. What are you feeling there?
So it's sharp.
Yeah, okay, so that's normal. And then down here.
Yeah, sharp.
Okay, so we'll just go to the other side.
That's not good.
Yeah.
Yeah.
So it's different to the other side again?
It is. It's different. Yeah.
And where are you feeling that when I do that?
So I can feel it where you're touching, but I can also feel it in that spot where it goes down my leg.
Oh, so that's reproducing that pain down your leg.
Yeah.
And so you would describe that as more painful when I put this on the knee there?
Yeah.
And lower down?
That's not comfortable down there either.
So that's different to that side. Yeah. Does it spread there, or is it just where I'm doing that?
Just where the toothpick's touching the skin.
Okay, so that's a bit like the light touch one that we did as well, isn't it? So a little sensitive?
Yeah, that one was worse.
Yeah. Any thoughts on what that means yet?
It seems to be more sensitive on the outside than the
I
back.
think that's a fair comment.
So repeated pinprick to the painful body part compared to the other body parts where the pinprick should be a noxious experience. You will describe it as sharp. Is it different to the opposite body part or a distal body part? Gives us some clinical information around hyperalgesia. Again, really, really useful. There's another one that I'm going to share with you. There's a pressure one where you can do light, moderate, and deep to be able to see if that causes an enhanced pain or noxious experience. I will upload it. I'm not going to play it now because I'm aware of time, but I do want to play temperature because I know that you will have been taught that with a tuning fork, which is simply not cold enough to do a temperature sensitivity assessment. It may tell you, yeah, that's cold or that's hot, but we want to know if this is colder or hotter than a different body part. And that is going to require an ice cube, and this is how we might do that. Stop share that.
Okay, Jenny, is that settled back down after that last bit of testing?
Yeah, it's fine.
Okay, so now we're going to try your response to cold. So I just want to try this on your hand first. Are you feeling that?
Yeah, I can feel that.
And what do you feel there?
Just cold.
Yeah, not uncomfortable, painful. So just on this knee. What do you feel there?
Just cold. Yeah. Similar to my hand.
Same, not painful or uncomfortable. Okay, so now I'm going to go to this knee. You ready?
Yep.
So I'm just going to hold that.
That's really uncomfortable.
That is. And where are you feeling that?
All that whole area under my knee. I can kind of feel it go down my leg.
Spreading the pain down your leg. I've taken it off now. What's happening?
It still feels like it's on there.
Yeah. Let's give it a few moments. Yeah. Sometimes the ice one can linger for a little while. Does it feel like it's settling now?
It's less. It's not gone, but it's less.
Yeah. Okay. We'll just give it a bit more time, and I think that will settle.
So hopefully that is helpful as a visual and learning aid for you to be able to see how we can try to test clinically for sensitization. And I've got research in a tendinopathy presentation that you guys will get at some point, because there's central changes that dictate ongoing peripheral presentations like tennis elbow, jumper's knee, Achilles tendinopathy, subacromial pain syndrome. all of those persistent pain presentations have a central changing component to it, and being able to assess that, these clinical tools that I've just showed you there with tissue, with an ice cube, with a pinprick, marry up pretty well to the really expensive quantitative sensory testing, and enough to be able to give us a picture that helps us to be able to get across, you know, everything we've been working on now, the research, everything's guiding us towards being able to understand that we've got a sensitized system to different extents, and how do we work with that. And that's what this information guides us towards. And Anna popped the question in there around, is this a real patient? Well, just bringing you back to this glossary here, some people are sensitized to the extent that a noxious stimulus like a pinprick is processed as more painful than it would be in another body part or in another person, and that's hyperalgesia. And some people are so sensitized that a non-noxious stimulus, so just touching somebody, is processed as pain, and that's allodynia. So that would be typically a more sensitized state, but if someone has allodynia, you could be pretty certain that they will have hyperalgesia as well. It's like a spectrum of sensitization that allodynia is one step below hyperalgesia. Does that make sense, Anna? So hopefully that makes sense, that hyperalgesia and allodynia, they're not like two different things that are invading the body. Pain is an internal experience. They are just descriptions of levels of sensitization. So if you've got allodynia, you'd be almost certain that you're going to have hyperalgesia as well. Okay. But being able to do that, and being able to do that on your patient, on their back, on their neck, on their shoulder, and then being able to get that interesting question, you know, this feels different on this side to this side. What does that mean to you? And then you show us that real patient there, opens up the idea, well, that side, yeah, that side, it seems to make more sense then. It's more tangible. This side is more sensitive. It's not always going to be the case, but it can be, and it can be helpful. And doing a battery of those tests can be a useful stepping stone in getting the information across for what you know is going to be helpful. If you can get your patients exploring factors that are sensitizing their alarm, then you are going to be getting them into a problem-solving mindset for being able to get towards self-management. Okay. Here are some characteristics of each of those factors that we mentioned as the pain mechanisms. Nociceptive, which is what most patients are familiar with, which is history. You'll have a history of damage in the last 6 to 8 weeks. You know, they'll describe an injury mechanism. Pain will be hopefully subsiding as the tissue healing takes place. You pull a hamstring, grade 2 hamstring, gonna be a number of weeks, 6 to 8 weeks, and as you load it, the pain will get less as it heals. That would be a nice nociceptive, predictable pain pattern. And it relates to the extent of the damage, often described as sharp, aching, or throbbing. Contrast that with your neuropathic, which is your 5 to 10%, where there will be potentially a history of a lesion. So I was deadlifting and I really injured my back. Well, that is a mechanism for a disc herniation to be able to be a cause of a nerve root injury, but often we'll have a nerve root injury from a spontaneous injury to a disc, because it happens all the time. People have disc bulges. It's common in people who don't have pain. It's people who do have pain. Depends on where the disc bulge is going to be as to whether it's going to be symptomatic. So there may be a history of trauma, but that is something that would have a specific plan of management, and that's why it wants to be probably second after your red flag triage for being able to get in terms of a diagnosis. Okay, that will often be described as burning, shooting, or prickling, and can be neuroanatomically logical in terms of a dermatome or a myotome, or just your characteristic radiculopathy into the back of the leg, which isn't necessarily a dermatome or myotome, but it conforms to what a radiculopathy pain presentation might come with. And then the final one there, as we've mentioned and we've been working through, is nociplastic, where the vast majority of our neck and back pain in particular, often shoulder pain as well, is going to be with no history of an injury, no history of damage, and there's no indication that MRIs and X-rays can be fine. Often they are if you x-ray somebody who is in their 60s, they're going to have wear and tear, and often the really important thing is people's pain gets blamed on what they see on a scan. But there's, in the vast majority, no medical cause for pain, and we have an illogical pain presentation, different body parts, and it's not anatomically logical and or connected to nociception. Several regions of hyperalgesia at sites outside and remote to the symptomatic area would be present. And what I've just taken you through in terms of a battery of tests is how you would test for hyperalgesia. You could also run that before and after a bout of exercise to be able to see if exercise-induced hyperalgesia can be helpful. But for all the reasons that we looked at in terms of primary exercise prescription in that descending inhibition presentation, that would require your caveats as to how you get that across. Seems to be dysfunctional in people who have persistent pain, but they still have all the general benefits of exercise if we can normalize and engage them with some pain. Lewis, so would FMS come under this? What do you mean there, mate? Do you want to just elaborate?
Hi, Luke. Like fibromyalgia.
Sorry, I thought you were talking about the functional movement screen.
Oh, sorry, mate. No, but fibromyalgia for allodynia.
Yes, absolutely. That is a really good example. Fibromyalgia or chronic regional pain syndrome. These are where you have all of your medical causes and lesions ruled out, and then these people will describe pain by their clothing touching them. They will describe it in multiple body parts, and that is widespread hyperalgesia and widespread allodynia. That's exactly what the mechanism we'd be talking about.
But if that was then to become a deeply ingrained belief, would that be hyperalgesia if it started progressing, the pain getting worse?
Your question is a superb one. Can you hold it for 20 minutes? Because that's, I guess, what I want you to finish by being able to answer that by the end of this session.
Okay, no worries.
But good, that's a great question, because we're about to lead on to beliefs. But this at this point here is mechanisms, and in terms of if you've got someone with fibromyalgia or chronic wide regional pain, then we're looking along the lines of nociplastic changes as opposed to nociceptive. Are we happy with that? Whether we can change that or not is, again, I suppose that's a very interesting topical area in research. But we've got to work with it clinically for the person that's in front of us. So that's some tests that, don't apologize, Lewis. That's a great question. But I said, rather than me answer it now, I'm just saying I'm going to try and answer it in 20 minutes. So that's some tests to be able to help get across and clinically present sensitization with your patients and your own clinical reasoning. And then I've also pulled from this Beale 2020 paper some key factors in the history that are going to give you an idea as to whether sensitivity is less or more of a factor for your patient. Now, you've got a caseload now, you've got people with shoulders, necks, low backs. These are going to be interesting things that I would want to slot into my history and take inform. I have these questions just simply I use a blank piece of paper, so I like to try and individualize mine, but you guys need to be able to have a guided history to start with. And I have these questions, and I don't do them in order because I want to try and make it conversational. But as I'm looking at my piece of paper, I will be saying, have I asked these questions? Because this information gives me information around sensitivity being more or less important. Okay, so simply from the body chart the patient fills in on the new patient form, you're going to see whether it's anatomically conforming to something you might see in a textbook or something much more common, which is going to be illogical and a little bit more widespread, and that's going to indicate sensitivity. A simple question here around, are you ever without pain? If someone describes constant, much more likely, okay, so there's going to be either a red flag here or there's much more likely to be an element of sensitivity. It's why red flag is very important to start, and people who have lots of sensitization, that can be a red herring for missing red flags, which is again why we have to be aware and diligent with our initial screening. Pain intensity. What level of pain do you experience at worst, best, and average? And people who will describe high levels of pain, 8, 9, 10, that is going to be a sign that this person has a heightened pain experience. Okay, spontaneous pain. Do you ever experience sudden bursts of pain at rest? How frequently does this occur? We know with nociceptive type pain that it will generally be loading that provokes it, not just spontaneously nervous system goes into bursts of protection. That's going to give us some ideas around a sensitized system. I've tried to put much of the important things from the paper into this so that you guys will have this, be able to use this as a resource, but I am also going to guide you to check out the paper as well. Other important questions that I would want to ask: do you experience pins, needles, or numbness? More frequently, so that gives an idea of sensitivity being prevalent. Do you experience sensitivity to hot or cold? Does hot or cold increase your pain? Sensitivity to touch. Do you get pain if someone lightly touches you, from light pressure or from your clothing or bed sheets? Are you sensitive to other things like smell, sound, noise? A lot of people can have sensitivity to various things if they're also sensitive to pain. Your aggravating activities are going to be things that fit nicely into your new patient assessment. So if someone's describing that everything, this hurts, ow, 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 everything hurts, again, gives me an idea around this person has a heightened pain experience. And working down here then to beliefs, where we get from the patient what their pain literacy is and what do they think is the cause of their pain. They will want to know what our opinion is around what the cause is, but it's often equally as important to know where they're at, because we can't guide and can't look at, as Lewis mentioned there, you mentioned beliefs there, Lewis. We want to be able to know what someone's beliefs are if we're going to be able to say, that's good, leave that be, or do I challenge it, and at what point do I challenge it? So that I have, there's some other questions in there that you can look at and decide as to whether you would like to put that into your questioning. They are very helpful for me, but this is something that has been super important for me right since I started in clinical practice. A, B, C, D, E, F, W. And this, Lewis, is how we collect beliefs to be able to put, I take from Louis Gifford, who was one of the real pioneers of a biopsychosocial approach in clinical practice. He was a physio, but this is how we get those beliefs, and we ask very critical question for getting what someone's attitudes and beliefs are. What do you think the cause of your pain is? And just listen, write it down. Behaviors, what are you doing to relieve your pain? Compensation, is your pain placing you in financial difficulties? Diagnosis and treatment, have you been examined for your pain, and are you worried that anything has been missed? Emotions, is there anything upsetting or worrying you about this pain at the moment? How does your family react to your pain, and how is your ability to work affected by your pain? So being able to have those important questions and passing and writing those down, collecting that information. If someone's not struggling to be able to come up with anything, then having some examples for how you might answer that for yourself. So, you know, I will often really, particularly with the pain neuroscience education, if people are struggling, try to lead the conversation. But really with this stuff, it's about trying to gather without guiding, to be honest, because we want to know where they're at, because the information that we gather from this is what we will then decide, do we need to reconceptualize this, or is this that's just fine? When we're asking what do you think the cause of your pain is, you know, we get in catastrophization, we get in maladaptive beliefs, passive attitudes towards rehabilitation. We're going to be hearing these things by that simple question, by asking what they're doing to relieve their pain. You know, are they relying on passive modalities? Are they using extended rest? Are they withdrawing from things that they enjoy? Compensation issues. It's a difficult question unless you just, you know, you've built up a conversation. You say, is this placing you in financial difficulties? It's an unfortunate, or it's a difficult conversation, but often people with whiplash have got some sort of medico-legal case that means that wellness is actually not, whether it's intuitive or deliberate or not, wellness, if you've got an ongoing court case for you able to be compensated, is not in your incentive to be able to get well. So you compare someone who's had a 35-mile-an-hour one road traffic collision and they've had pain for a year, 2 years, and longer, versus someone who has like Derby Valley drivers where they have 35-mile-an-hour crashes hundreds of times a year. They don't have higher rates of whiplash than people who haven't had car crashes. So what's the difference there in terms of a tissue-based perspective? The Derby drivers are having way more collisions, but one of them is doing something that they love versus one person who's been hit up the arse and their car's ruined and the other person didn't say sorry, and all of these factors that's going to dictate turning nervous system up and down, and again the incentive for our nervous system to calm down. Diagnosis and treatment, key question. Have you been seen and examined? Have you been seen and examined by somebody else and you're worried anything's been missed? When we ask that question, we're going to get what literacy people have got, and most often it's going to be from other healthcare professionals. And unfortunately, a lot of that might be not agreeing with what you want to be able to get across. So then you've got to be able to marry up when, do I challenge this, or do I want to say that that's fine, it's not affecting their getting to what they need to be able to do, and that's fine. Expectation is super important, Lewis. That's going to be entwined with all of these factors, because when we looked at the session on descending inhibition, you know, that is one of the things that will turn on or turn off whether nociception is coming in from a body part. It'll amplify it up, or it will stop it from synapsing. So these are going to be important for asking what someone's beliefs are when they come in to see you, because you may want to challenge or change some of those things. And how do we go about doing that? Well, that's where motivational interviewing is something that I want you guys to be able to be exposed to. You may be familiar with it. If you are, then fantastic. Hopefully you're acting on it, because this is where we influence behavior change. This is where we're aware of the readiness to change for pre-contemplation, contemplation, action, to be able to engage with, right, I've smoked for years, I'm ready to stop smoking. If I keep telling you smoking's bad for you, you're going to dig your heels in and put two fingers up and you're going to carry on smoking until you're ready to change yourself. Unless I can sow a seed that means that you can become ready and open to exploring something before that point. And that's really what motivational interviewing is all based on. It's a counseling style born in addiction, but increasingly more and more used for public health. And this paper I will upload is a manuscript in different ways of dealing with resistance to behavior, even though people want to change. You know, if any of you have had something that you do, and you may say you're addicted to it, take something that you love, smoking, chocolate, whatever it may be, you want to change, but there's still that resistance in your behavior to be able to change. And that's what a lot of your patients will be facing when it comes to health behavior change and physical activity and exercise adherence and all of these things. So motivational interviewing has been defined as person-centered method of guiding to elicit and strengthen personal motivation for change. Core clinical strategies include reflective listening and eliciting change talk from your patient. It encourages individuals to work through their ambivalence about behavior change and to explore discrepancy between their current behavior and broader life goals and values. A key challenge for practitioners is deciding when and how to transition from building motivation to goal setting phases and action, the counselling. Okay, so there's a model in there for how you go about that, but I've got a video because what we've been doing in practice with our chalkboard is fundamentally motivational interviewing in action, and that's something I've got an hour-long video for you guys to have and look at how we've done that. And also the pain neuroscience education, as I've been saying, when you're delivering these, you can't just give people information. It has to be interactive, and if we can get the person involved to be able to be coming up with decisions or being able to at least be given the chance to discover their own thoughts, they're much more likely to act on them. I know that no matter what I tell you guys today, you're much more likely to stumble across something that maybe I exposed you to, and if you perceive that you discovered it, you're much more likely to follow through and act on it than anything that you're told to do. That's just humans. I'm the same. We're all the same. So being aware of that is how we sow seeds for behavior change. The important things in doing this, and what the title of this slide is really to sum up, Lewis, the whole question that you asked there before. Do I challenge this belief? And if it is a belief, what do I do about it? Because we have to, at some point, be able to comfort the afflicted, be that ear, be that listening person for just not trying to offer solutions, not trying to impose our thoughts, just being able to accept what someone's going through and being that ear. And at some point, we will then also have to afflict the comfortable, because that behavior is not going to get them to doing the things in the long term, and being able to know when that transition takes place. I have a funny video. If you've seen it, then fantastic. If you haven't, then you'll remember it, and it'll come into play in every history that you will ever do.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you. It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Come on. If you would just.
Don't.
Try to see things my way. Do I have to keep on talking till I can't go on?
It's a funny little video, but there's a powerful message in there somewhere, and that's really the essence of motivational interviewing, is to know when to just listen and when to tell somebody that you need to take the nail out. So that is that's hopefully some food for thought in terms of the next time that you're facing these challenges when you're communicating with your patient. If you watch the videos back of the collaborate sessions or the pain neuroscience sessions, I have uploaded or done with you guys, they are largely done in an motivational interviewing way, trying to make things conversational so that a person can try and come up with the ideas and the answers themselves, because if someone does, far more likely to follow those through. Very famous, I think it was Benjamin Franklin's right-hand man, who Noah knew that if he could make Franklin think that an idea was his own, that he'd follow it through. So that was his whole job, was sowing these seeds to be able to influence behavior change. But listening, validating a presentation shows, and we've got to be able to take all the information as we're taking A, B, C, D, E, F, W without judgment, to then help guide someone towards self-discovery, towards the process of where their end goals are. Okay, often need to resist the desire to offer premature advice or suggestion, which that video hits the nail on the head in that sense. So I've put in green there that a big part we have to often do is roll with resistance. And that's something that is in the motivational interviewing paper there, that some things are just not ready to challenge just yet. So we have to pull up and park alongside the patient, and then slowly sow seeds over time. And I'd love to be able to spend more time on these sessions with you, but I want to make sure that you've got resources to be able to explore this further, because this has been incredibly helpful for me in practice. So this is from the NOI guys, which is the authors of Explain Pain, where they look at levels of misconception to establish what someone's beliefs are and know whether we can challenge those or not. Okay, so they use this metaphor of missing bits, single grain, sandcastle, or sandstone, to be able to see how we would go about whether we challenge it or not. So a missing bit would be the simplest one. This is where learners have reasonably accurate concepts but are missing a few key pieces of information. Education in the face of missing bits isn't really conceptual change, it's more gap filling. So often the NOI guys will use the example of a person who presents worried that they've got a bursa in their painful knee, and they're worried that that's a cyst or a foreign object that shouldn't be there. And the gap to fill in that example would be that many people have, well, we all have bursas in our knees. They're a natural part of our anatomy, and that they're for protection, cushioning, friction, and they can become painful and a source of danger signals for some people. We can do lots of things to help that. And that would be gap filling that could be done in real time, part of the reporter findings, or ongoing, just your dialect and conversation with your patient. There's no conflict there. There's no challenging of deeply held ingrained beliefs. That is just a missing bit. Okay, so just giving people updated information is what solves that. Now, the next level of the metaphor is that called single grain misconceptions, where a grain of knowledge can be considered a single concept or a small cluster of concepts. Single grain concepts are held loosely and are not deeply connected to other single grains to form more mature or elaborate concepts. Common single grain misconceptions include ideas that it's just old age or my back is out. You'll hear these things, right? Single grain misconceptions, because they are not held deeply, can be tackled head on, respectfully, refuting the existing misconception and giving them new information. Example being, age has nothing to do with it. Age is not a pathology. In fact, we know that age and pain are not really linked at all. Perhaps consider this. If it was an age problem, wouldn't your left knee hurt just as much as your right knee? Or is your right knee older than your left knee? Humor, and that's again why Robert Sapolsky that I introduced last week is the best out there that I've seen. Lorimer Mosley from the NOI guys, these guys work on their comedy, their stand-up comedy, because they know that humor softens the ability to get across information, and ultimately the more challenging patients, that is going to be more important. It takes the edge off conflict, but being able to tackle those ones head on, we can do successfully. So the next level of misconception would be a sandcastle. So these are held more deeply as multiple concepts, and they link up to form more elaborate knowledge structures. Sandcastle misconceptions include ideas such as I have pain, therefore I'm damaged, or it's not safe for me to move, bend, or exercise while my back hurts. The individual grains that might be part of both of these sandcastles include every time I move, I can feel it grinding, It cracks if I stretch. Listen to this pop. You can hear it. Can you hear it? Can you hear it? You'll have patients coming up to you. Once you've hurt your back, it's never the same again. My x-ray shows severe degeneration. I was told I have an upslipped pelvis. Sandcastle level misconceptions can be taken on in 2 ways. Replacing the whole sandcastle at once. So that would be giving someone the persistent pain book that I've given you guys to completely replace their previous belief system with this all in one go, or grain by grain, which is how I would do things more often myself, which would be like a wave gently washing away the sandcastle, which extends the metaphor. So each week you maybe introduce a little bit more, okay? Both take skill, deep knowledge, and likely some time. Explain Pain, or that booklet I've given you, is a kind of holistic confrontation, taking on the whole pain sandcastle at once, replacing misconceptions with new and more accurate information about pain and the body. Attempting holistic confrontation might lead to actual confrontation and is not for every patient or clinician. And you will find when you start, to bring you back to what you said before, Lewis, when you start challenging deeply held beliefs, this is where you're talking about, because we have to have a bit of skill and nuance in being able to deliver that, because it can go the wrong way when we are challenging deep beliefs. Take time to explore the sandcastles, and teasing out single grains can allow a more gentle approach of tackling one or a few grains at a time. And in the examples above, perhaps you might start with, let's talk about your x-ray this week. That's all we're going to cover. Then we'll maybe look at something next week. 1 grain at a time. But it's possible with sandcastles if we apply a little bit of nuance. The final one, and it's nearly 12 o'clock, is Sandstone. Okay, and these are where we have firmly fixed mental models. Misconceptions can be held so strongly that they exist at a sandstone level. This is where the metaphor really shines, as we're all familiar with ideas and beliefs that are held so strongly that not even a metaphorical sledgehammer could dent them. My suffering is God's will, or it's a massive disc herniation. 4 surgeons have told me that if I don't have surgery, I will end up in a wheelchair. Even I can see it on an MRI. Nobody can help me are examples of conceptualizations that are held very tightly with multiple overlapping concepts in place. You may be bumping up against mental models based on culture, religion, long-term biomedical exposure. Okay, that's something that you should be able to see the relevance of big time when dealing with sandstone. And one question to ask is, do I have the right to challenge or change this? Is there any point in me being able to try and challenge this? A nimble and adaptable clinician could try to educate from within the person's concept of finding and speaking their language and not directly challenging it. After all, even sandstone can be chiseled and chipped away at, or maybe you don't try too much at all, hope that you can plant a seed that sometime flourishes further down the line. Okay, so this is basically appreciating the levels of misconception to know with some people, no matter what information I have, I'm not the right person, it's not the right time. I need to be able to say that I'm not appropriate to be able to help them at this point. And I've had to do that. Okay, now I'm going to just roll this on because I'm going to upload this to your Blackboard. And I'm going to give you an example of a 60-year-old male. The case is in the first week on Blackboard, so you'll be able to see the answers or my clinical reasoning, but this should be something I want you to take into your clinical caseload. He had 40 years of history of low back pain and leg pain, and he passed all my physical examination. Okay, full neurological workup, orthopedic test, pass everything. But he's had pain, still got pain, and from the A, B, C, D, E, F, W, the beliefs that I collected were that he was certain that pain was due to a trapped nerve and arthritis, convinced bending was harmful and avoided for years, and he had an anterior pelvis. What are you doing to relieve your pain? He would say he's resting when painful, which is most of the time, stopped walking as he's too painful, and he stopped flexing his spine. Showed me when I asked him to bend down and pick something up, a bolt upright sissy squat. He was told by his orthopedic surgeon 30 years ago when he was in the military that he had a punctured vertebral disc. When asked on E, are you concerned about anything? He was very defensive of any suggestion of an emotional or psychological component to his pain. He had a deeply ingrained structural belief. Okay, so I've got to wrap up there because I've got another group. But what I want you to do, and I know not everyone will do this, is to think about this. Think about what levels of the misconceptions these may be, from missing bits through to sandstone. How might you challenge this to be able to take these ideas into every patient caseload that you're working with? And if you go back to week 1, you'll see the entire 90-minute webinar that shows you how I went about this to be able to address and build the rehabilitation program based on this. Lewis, I'm going to have to sign off the session now, but there's a 90-minute webinar showing videos and every step in week 1 on Blackboard. Okay? I hope that was helpful for your initial question there, Lewis, because there's no correct answer. You can hopefully make that nuance yourself as to see how you might try and maybe wash away one grain at a time, or try and replace it all in one go, or say it's not appropriate.
Luke, my question was, like, where allodynia and hyperalgesia are a little bit different. If, say, for instance, someone had fibromyalgia, which maybe would be an allodynia because there's no exact cause for the pain, can that then lead to hyperalgesia because of beliefs being ingrained after that?
Yeah, I mean, that's now you're talking about clinical nomenclature, or however that word is, in that ultimately the person's pain experience, they're going to describe it to you. And in terms of whether it's allodynia or hyperalgesia, it's just in terms of mechanisms for yourself. And it tells you this person is much more wrapped up than if there's allodynia versus if there's hyperalgesia, as opposed to it being passing between one or the two. That's more about just understanding your own clinical reasoning.
Yeah, okay.
All right, pal?
Yep, thank you.
Cheers, guys. The guys that's week 8. I hope you've enjoyed this. Keep watching the final 4 weeks, because there's going to be stuff in there that you guys haven't covered, and vice versa. I will see the rest of you next week. Cheers, guys. What did anyone want to add? If anyone wants to email me their answer to this, and you take the time to do that, I will take the time to respond. So that's something that I wanted to say as well. Okay. Cheers.